Hi, and welcome to AAHPO's American Armenian Health Professional Organization's TV health program. We are continuing with pharmacist Vatche Demirjian, who is postdoctoral associate professor at Rutgers, with the conversation of medications interactions. Let's continue our discussions that we had on last program. We were talking about the medication and their interactions. So certain medications that we take, they have interaction with other medication. Right. Let's go over them and give us some information about the interactions.
Sure. So I like to think of four main interactions that can occur. We can have a loss of therapeutic effect by taking two medications. One interacts with the other. We can have an increase in side effect profile because you're taking two medications and we might boost the effects negatively.
Augments the other one effects.
Right. We might purposely boost the effects, so we want there to be a drug interaction so that it increases the concentration of one of the medications.
I'll give an example, like Augmentin.
Like an Augmentin with clavulanic acid. It purposely, the clavulanic acid inhibits the breakdown of the amoxicillin so that we have higher amoxicillin concentrations.
More effective.
More effective, right.
Okay.
And finally is chemical incompatibilities. So an example of that would be like a lot of patients take levothyroxine, which is a
thyroid medication.
Very common thyroid medication. If you are taking a calcium-containing supplement at the same time, or milk, or eating, or anything like that, it could affect the absorption of the levothyroxine. So we want to space it out so that they're not going to interact with each other.
As a matter of fact, in the practice, I tell the patient that's the first thing. You wake up,
before
you do anything, take your thyroid medicine, wait for a while, and then start doing things.
Exactly, exactly. When we talk about the loss of therapeutic effect, we can take two medications that will decrease the concentration of one of them. So an example of this, paroxetine, which is a very common serotonin agent used for depression. If you're taking something like codeine at the same time, the paroxetine inhibits the metabolism of codeine to its active form. So if you're decreasing the ability for codeine to become active and take effect, you're going to have less analgesia and less pain control.
Because the clearance is the same way through the liver.
Right.
And then one potentiates the other one, or decreases the effects. Okay.
Right. Another type of interaction when we talk about increase of adverse effects, Lipitor or atorvastatin, which is a very common cholesterol medication that a lot of patients are on. If you've ever looked at your pharmacy vial that you've gotten from the pharmacy, there's always a little sticker that says, do not take grapefruit juice at the same time as you're taking this medication. And if you've ever wondered why that is, it's because grapefruit juice actually increases the concentration of the atorvastatin or of the Lipitor. This can have a negative effect because it's going to increase the adverse effects. So you might have more muscle pain, muscle weakness, rhabdomyolysis, and you're going to have an increase in these side effects. And so that's why we say don't take it with grapefruit juice.
Right. But usually we say, probably to my patients, I say in the practice, don't take any medicine with the grapefruit juice. The other thing is important that we were talking before we started the program, we were talking about the patients going different pharmacies and purchasing half medication from one pharmacy and the other pharmacy. Let's talk about that.
So every time you go to the pharmacy, in your local neighborhood pharmacy, and you pick up your medications, the pharmacists have the ability to check for drug-drug interactions. There's special software that's out there that are utilized by the pharmacy. So if you go to two different pharmacies, so let's say a CVS or a Walgreens, and you have half of your medications at one pharmacy and half at the other, the two systems are not going to talk to each other. They don't have the ability to check across the companies. If you go to one Walgreens and then another Walgreens, all your medications are still at Walgreens, so that's okay.
Sometimes, even if they go to another town or another city that they don't have that kind of pharmacy, we say usually carry your medication list and show to the pharmacist. So these are the medications that you're taking from other pharmacists, so they can put in the system, so they can see really what doesn't go with the other one. Let's talk about a little more about the hospital-based pharmacy situation, which is more controlled, because when physicians write the medications, go through the pharmacy. What are checkpoints that you have in the pharmacy in the hospitals?
So a lot of the
patients should be comfortable that it's being really done properly.
A lot of the newer work strategies in hospitals are actually having pharmacists on the floor with the physician team that's rounding with the patients on the actual floor. I know that our transplant team at the hospital, the pharmacist is the one who enters all the orders. The doctor suggests, I would like them to be on this medication, but based on their kidney function, based on their liver function, based on all the other medications that they're on, they trust the pharmacist that works with them on the floor to write all of the medication, the doses, the times, etc. In situations where there's not a clinical pharmacist on the floor, some things that are being done in the background is every time a doctor writes an order, we check the liver function. We check kidney function. Kidney function is a popular one because we need to renally adjust some of the dosages based on the kidney function.
Right, and it's properly calculated. So
right.
It's very much easier than the liver function
exactly.
test to calculate better.
Right. And some medications, even there's protocols. Vancomycin is a very commonly used antibiotic in the hospital. Some hospitals, the physician will just say vancomycin, and the pharmacist doses the medication, they check the levels, they check to make sure when the frequency should be, and they leave it up to pharmacy to dose the whole medication.
Well, which is the right way, actually, because the pharmacist will have that program and will adjust the dosages as it goes on.
Exactly.
And certain times there's a automatic blood test checking, like vancomycin every third day.
Right.
Blood test, the level is automatically checked for the pharmacy, and pharmacy adjusts the dosages for
as needed. Right.
So the patient should be comfortable in the hospital saying that, okay, I'm in the hospital now, I shouldn't worry, because the prescriptions are all going through the pharmacy, and pharmacy is really doing. And as a matter of fact, some hospitals, they have even specialty pharmacists. Like we have in the hospital pharmacist that only deals with antibiotics.
Exactly. Right. So at our institution we have the same. So sometimes there are specialists that just deal with infectious disease or just deal with nephrology or dialysis type of patients. Also, emergency medicine is now a popular one where there's actually clinical pharmacists that staff that area, the emergency room. And actually there's one medication called TPA. So if you're having a stroke and you need to go to the hospital, the pharmacist is the one that doses the TPA and figures out how much do we need to give, and is the one that actually administers it.
If they go to pharmacy, first they should do then?
So first thing to do, always the best thing, is to have the most up-to-date list of medications on you with regard to not just the medication, but the dose and how frequently you're taking it. The second suggestion I think would be wise is have all of your medications at the same pharmacy. This allows the pharmacist to really do a full job in assessing all of the medications that you're on and evaluating for drug-drug interactions. Also, not just prescription meds, but make the pharmacist aware or your physician aware of any over-the-counter supplements that you're taking. And not just supplements, but Tylenol and Advil. You know, patients that have poor kidney function should not be taking Advil. Patients that have poor liver function should not be taking Tylenol. And so those are two easy things that can easily go under the radar if you don't bring it up to the attention of your healthcare provider.
And I always say, up-to-date your allergies, because sometimes you have only one or two allergies, and then one medication comes in and you're allergic to, you have to inform the pharmacist too, so they have to put in, because physician might know, but not necessarily the pharmacy might know. So when they go to pharmacists, it's saying that, okay, I had a reaction to such and such medicine, so please write it down on my list so that I have that allergy, particular medication.
And we worry a lot about that when it comes to antibiotics. Sulfur, for example, patients can be allergic to sulfur. There's a popular medication called Bactrim, which has sulfur in it. So if you're allergic to sulfur, you cannot take that medication.
There's actually so many medications like that, and sometimes they label that as an allergic, but actually they have some sensitivity, not necessarily allergic. So I want them to be careful too.
And when we say an allergy, we mean an immunologic response to a certain medication. So, you know, if you have a side effect like constipation when taking opiate medications, well, we know that that's a side effect. That's not an allergy. So sometimes in the patient's medical record, it could be documented as an allergy, but it's not a true allergy. Conversely, if you've had hives, if you've had trouble breathing, shortness of breath when taking a penicillin, for example,
or any of them,
that's more of what we call an immunologic response, where that might be an allergy, a true allergy. We'll be able to identify if a physician accidentally writes a medication for you that's going to cause an allergy to happen.
Well, this was a great program. Thank you very much for coming to our program. Now it's time for this week's article, and it is whey protein, which is in dairy products and cardiovascular disease. Cardiovascular diseases are our greatest cause of death globally and in Western countries, and the reduction is a key public health target. The prevalence of cardiovascular disease is growing because of the increasing aging population. One of the modifiable risk factors for cardiovascular disease is high blood pressure. Untreated high blood pressure can have serious consequences such as stroke and organ damage. An improved quality of diet can decrease blood pressure. Some studies have shown that milk consumption is associated with lower blood pressure. Recently, researchers from United Kingdom and Italy investigated whether milk protein lowers blood pressure and other risk factors for cardiovascular disease. Participants were divided into 3 groups. They were assigned to consume either 56 grams of whey protein daily or 56 grams of calcium caseinate daily or controlled drink for 8 weeks, and they were crossed over after 4 weeks of break from their drinks. Significant reduction of both systolic and diastolic blood pressure were observed after whey protein consumption compared with controlled drink intake. Also, milk protein improved blood lipids by decreasing total cholesterol and triglyceride level and improved arterial stiffness. So conclusion of this study was whey protein, which is in dairy products, lowers blood pressure and improves arterial stiffness, cholesterol level, triglyceride level in adults with high blood pressure or pre-hypertension. So have 3 servings of dairy products, milk, yogurt, or cheese daily for your daily calcium requirement and help your blood pressure and lipid profile. Good health is precious and priceless. Keep up to date. Visit AAHPO's website, aahpo.org. I'm Dr. Ohan Karatoprak. Until next program, so long.